Before I talk about the core findings from DeStress, I just want to flag up some of the different types of narratives that influence the way that people in low-income communities experience mental distress. Now, the ladies here have actually covered quite a lot of this already, thank you. We're going to talk about that and the way that patients and GPs respond to this. And that's really important because we found that these narratives really underpin the way that people feel about themselves and the way that other people see them or are perceived to see them. And these narratives, in turn, help to explain our core findings. So firstly, we have this neoliberal narrative, which is very much linked to the idea of responsibility, where people with distress are seen as having social or behavioural problems that they need to sort out themselves. And this kind of narrative very often leads people to people feeling guilty and helpless. Closely related to this, we've got this shame narrative, where people who are not seen to be acting responsibly are seen to be engaging in reckless and irresponsible behaviour, and in so doing, they become a problem to themselves and to society. That's the way it's very often viewed. And this often leads people to fear that they're going to be judged again, and it leads to people avoiding seeking support. We've also got this medicalisation narrative, where mental distress is seen as a pathological issue requiring medical intervention. And what we've seen throughout the project is the real chaos that these narratives cause, alone but also in combination with each other. And they cause this chaos not only for patients but also for GPs as well. And we're going to talk through some of this in the findings. So the first area I want to discuss concerns the range of systemic stressors that impact on people in low-income communities. The majority of people we spoke to in focus groups felt that they're constantly framed through a deficits approach, in which material deprivation is equated with deficiency and recklessness. So what I was referring to before as the neoliberal and shame narratives. So people are blamed for what they eat, the condition of their housing, the way that they live their lives, that they're frequently told by service providers that they're lucky to have things, they're lucky to have anything. Now, this isn't unique to austerity, it's been going on for a very long time, but certainly there's a perception that this kind of, these narratives and this rhetoric around being lucky, you should feel you're lucky to get anything, that's really intensified in the last few years. And this moralising talk around responsibility is really pervasive. Residents are extremely aware of these narratives and encountered them in their everyday lives from organisations such as schools, health and social workers, particularly job centres. And it's also very clear that a lot of these narratives come from within the community itself. This has knock-on implications to the way that people present themselves to others, the way people speak, sometimes the way people behave, the way that they dress. And all of this is according to what is and what isn't seen as acceptable for people on low incomes, particularly if they're in receipt of welfare. It also has toxic impacts on levels of trust between residents and service providers and within communities themselves. And very importantly, we found that many of the people we spoke to, particularly with those with young children, as Hills was saying a minute ago, they actively avoid seeking support services if they feel that they're going to be unfairly judged because of their background and circumstances. And we have many cases of people taking themselves out of systems that they felt were not providing support to them because they feared that, at the end of the day, their children may be taken away from them. And you can see this in the quote here. I was made to feel because I had some sort of depression, I was obviously a danger to myself and my child. We found that just engaging with the welfare system was a really key source of stress. This need to attend regular appointments which don't take into account unreliable and costly public transport, people's caring responsibilities, their medical appointments and so on. The fact that people have to provide sufficient evidence of job seeking, which requires access to computer and internet due to the digital by default strategy that the government has these days. And when they're doing this job seeking, it's very often for very limited and usually very precarious work opportunities. This need to keep in line with the array of changes to benefits and the associated rules that have been enforced in recent years, to deal with and challenge what many people described as frequent under or delayed payments or benefits sanctions. This idea that you have to be better, you have to show that you're bettering yourself through voluntary work placements, and to display this sort of work-ready psychology to convince people, benefits advisors, of your credibility. All of these things come together to present real stresses in people's everyday lives. And that's in turn underpinned by what people described as a guilty until proven innocent approach to assessing claimants. So people reported frequently being disbelieved. And you can see this in the quote here from a GP who says that the work capability assessment people just don't believe people anymore. And this GP has to write letters of support all of the time to support his patients. We've only got to think about the government's reaction to the UN Special Rapporteur report that came out at the end of last year on austerity in the UK. We've only got to think about the denial of people's realities and concerns around Grenfell Tower to see this pervasiveness of this form of denial. Add to this, of course, the stress of going through things like the work capability assessment process when the evidence of GPs is often overruled by someone who's barely even met the person that they're assessing. And when the assessment itself is very clearly set up to examine physical rather than mental health. This idea that work at any cost is good for you, even when the work available to you is more likely to actually wreck your health because it's precarious and insecure and low pay. It's that sort of context that we're working with here. And we know, as was mentioned earlier, there's been widespread deterioration of services as part of the impact of austerity. And this has resulted in the closure of really important social infrastructures like libraries, support groups, all these places that previously offered the possibility for connection and community. We also know that reforms have commonly displaced people from the communities in which they once lived. So Debbie, who was talking earlier about the regeneration of Devonport and the millions of pounds that were chucked into it, what we've also found, of course, is that many people have been moved out of Devonport into communities that they don't have roots in. It's all placing huge pressure on people with low incomes. But as Richard mentioned, it's also placing huge pressure on the GPs who are seeking to support them. The GPs we spoke to all reported a rise in cases of poverty-related distress in recent years and real frustration over the lack of support available to address the constellation of issues that people might be facing that are associated with mental distress. So things like alcohol and substance abuse, you could tend to be able to get support to address single behaviours, with further support only being accessible once that single behaviour has been addressed. So you can't address everything in one go. What we also found, though, was that there was no unified response to poverty-related distress, and that very often GPs would completely medicalise mental distress, or they would discount distress as being a purely social problem, even if they then prescribe medications as a response to that. So this leads us on to the medicalisation of poverty-related distress. So we've said that resource cuts mean that there's very few other services available to people these days, lack of community groups, CAB, and so on. And that means that people are more often going to their GPs to get support. And by the very nature of clinical settings, the likelihood of distress being medicalised is very obviously going to be increased because you're in a clinical setting. Many people also felt pressures to legitimise their stress to themselves, to their family, to their friends, and to the services they dealt with, like job centres. And while they're constantly being blamed for their circumstances and told how lucky they are to have anything, there was an implication that people who are experiencing the challenges of poverty should see any associated distress that they felt as a problem that lay within their own pathology, rather than an issue that stemmed from the structural inequalities that they faced across their daily lives. And in such situations, we found that people were actively encouraged to seek medical help by their friends and family very often, or themselves had invested in medical narratives around the normalcy and need to see and act upon themselves as if they were ill and in need of treatment. Now, of course, what we have to remember as well is that medicalisation is actually necessary these days for anyone who wants to remain within the welfare system, or anyone that needs to remain within the welfare system. So one thing that emerged from our interviews was that people felt that they had to either be seen to be taking control of their lives, either by not bothering people through seeking support, or by adhering to what they were told by their GP. There were many cases when people wanted their GP to see that they were really trying to be proactive in helping themselves to get better. And very often this involved accepting medications, even if the patient didn't really want them or believe in them, and ultimately even if they didn't then take them. And you can see this in the quote here. I felt if I had turned around and said, well, I don't want the tablets, they'd probably turn around and say, well, you're not that depressed then, are you? You don't need the help. And the participant here says, I took them for 3 months just to pacify people, really. There were people in the study who actually wanted us to let their GP know that they were involved in this study because they wanted to show their GP that they were proactively trying to help themselves, which I thought was really interesting. And there's this sort of feeling that if you weren't seen as trying to help yourself, then you were in some way defective and less deserving. Now, linked to these issues, we found a really huge level of dissatisfaction with the current medical model for mental health. In particular, we found that GPs often feel very pressurised to give a diagnosis and to try and fix the patient sitting in front of them. Now, GPs are also these days placed in a very difficult position as gatekeepers to welfare. And this places real challenges on them in terms of things like when to diagnose, when to give medications. And what we found was that it was very common for GPs to over-medicalise, actually in order to help people to get their benefits. And you can see that in this quote here. Also, real dilemmas placed on GPs around when to give people a sick note, now very tellingly named fit notes these days. And our analysis of the video recordings found that the level of uncertainty around how to respond to socially and structurally induced distress meant that GPs were usually less likely to offer fit notes for people experiencing mental health issues rather than physical health issues, and that patients really had to work a lot harder to get fit notes from their GP here. Again, real frustration amongst GPs when their decisions and their expertise were overruled by work capability assessment processes, and real frustration that very complex circumstances facing people essentially boiled down to two treatment options. So if we look at those treatment options now, we can start to see how limited they are. Use of antidepressants in the study sites was very high, and what we found was a real paradox of long-term use, quite often ongoing use for a number of years at a time, although more commonly as episodes of medication use, with quite often quite a sporadic adherence. The GPs we interviewed generally felt that medications were an easier option for patients with complex needs than talking therapies, although they actually recognised that it wasn't going to solve the problems of that person. And we have a lovely quote from a GP here who says, "I think the perception is, certainly amongst GPs, that something like fluoxetine is a very safe, fairly clean drug, so it won't do very much harm. So it feels like a kind thing to do if you've got somebody in a situation that can't be changed, to prescribe them with medication that makes them feel slightly better about the situation. There isn't good evidence to support it, but we still do it." And of course, there were some people who did find medications helpful. We don't want to say that all medications are bad. Obviously, for some people, medications do help. But the dominant narrative that we found amongst people involved in the study was that people felt that medications were being overprescribed, and that people felt that there were not enough opportunities for medication reviews or to help them stop taking medications. And that as a result, as the lady said earlier, people very often felt really fobbed off by this process. If we look at talking therapies, now again, the data show a good take-up of talking therapies across the country. Like other studies, we found a large range of logistical and sociocultural barriers to their use. It's very hard for people to attend talking therapies when they're in insecure employment or on 0 hours contracts, when people have childcare needs, when they have to pay for transport and so on. Many people are reluctant to talk to a stranger, or they're reluctant to talk in a group, and they felt that this support just wouldn't be very helpful to them. And the most common way to access IAPTs, the talking therapies, is through self-referral, where you as a patient refer yourself into the system. And this notion of self-referral is very often seen as a first step to recovery. And our analysis of the video recorded consultations and our interviews with GPs showed that GPs commonly emphasise how easy it is for patients to self-refer. As Jenna was saying earlier, GPs will say things like, well, it's just a phone call, just pick up the phone, like it's a really easy thing for someone to do. But actually, many people we spoke to found that this idea of self-referral was a real barrier for them to access talking therapies. They spoke about the courage that they'd had to get together just to get to the GP in the first place, only to then be given this leaflet by their GP, which some people sort of felt as a symbolic dismissal. It obviously then deterred them from returning at a later date. There are also big issues between the delays between the initial assessment that you get for talking therapies and then any sort of substantive step 3 support. The one-size-fits-all approach to IACT was widely seen as failing to address or find solutions to people's underlying causes of distress. And again, it was widely felt that much more personalised and solution-focused approaches that aim to alleviate everyday pressures of hardship would actually be more helpful to people. Enormous frustration amongst GPs and patients around the fractured nature of mental health provision, particularly around the difficulties faced referring patients on to appropriate secondary mental health care. And this was a particular problem in one of our study sites where patients very often refused access to the talking therapies at a level that's any use to them because their needs were considered to be too high. And what happens then is they're just referred back to their GPs rather than on to more specialist care. So people are kind of left churning in the system. And of course, this in turn creates a fairly unnecessary burden on GPs' time and resourcing as well. So overall, this sort of real despair at what seemed to be a hugely problematic disconnect between primary and secondary mental health care. GPs often felt they had few options available to them to really meaningfully help people experiencing poverty-related distress. And we found a real lack of satisfaction amongst both patients and GPs around the treatments that are currently on offer. The conversation analysis data show a general lack of endorsement amongst GPs for both medications and talking therapies. And this is really important because it means that patients are actually leaving the consultation not feeling very hopeful that the treatment that they've been given is going to work. And we know that things like the placebo effect are, they are quite helpful very often. We found that GPs faced increasing possibility of stress and burnout when they're repeatedly seeing so many patients that they don't feel they're able to provide appropriate help for. So just some key messages really. What we've said is that the figures on mental health treatment look quite positive, but actually in reality, people from low-income communities face a number of difficulties in accessing support, and when they do, the support that they're given is very often not actually appropriate to their needs. We found that effective support is being undermined by a system of rules and narratives which create a paradox where people are told that they're a problem and made to feel like they're undeserving of support or some sort of form of risk that needs managing. And both of these things drive people away from seeking support and care. Yet at the same time, we have drivers in the welfare system that actually push people into seeking a diagnosis and treatment that's quite often inappropriate and very disempowering. And a situation where GPs feel that they have very few options available to them that do not actually exacerbate over-medicalisation. And this leads on to an overarching and concluding theme for this session, the need to reconceptualise responses to poverty-related distress. So the aim here is to think about developing a third way between just blaming neoliberalism and all its ills and absolving people from all responsibility for their own lives. Now, whilst of course not condoning the current situation of poverty and austerity in any way at all, we do need to recognise agency and that people can overcome adversity through action that doesn't necessarily involve medications. So this conference is about working together to build on our insights collectively in the room and to consider how we can work together as community groups, researchers, practitioners and policymakers. One of the key questions that we've been looking to answer is how we can create a more compassionate, evidence-informed and sustainable general practice response. We're going to focus on this a bit more tomorrow when we talk about restructuring the GP consultation and the training materials that we're developing. But in brief, we need to ensure that people feel that they're still able to go to their GP to talk about mental distress. We know that the connection between a patient and a GP is really important to people. But we need to shift away from seeing GPs as fixers who feel under pressure to diagnose and to provide medications, to give them a more supportive role that recognises the biopsychosocial and is also aware of non-medical forms of support. And we need to dilute the responsibility away from just GPs to other sectors and to communities themselves. We need coherence between the third sector, mental health providers and primary care responses. We need to consider how best to support individuals to look after themselves without blaming and overburdening people. And as a part of that, supporting individuals to work together and generate well-being despite adversity.